set.
Go ahead.
We're set?
Yep.
Ladies and gentlemen, good morning. My name is Tom Gretsch. I'm the president and CEO of the Queens Chamber of Commerce. Welcome to our program, To Vaccinate or Not to Vaccinate? That is the question. A town hall discussion put on by our Healthcare and Wellness Committee to talk about your questions and comments and concerns about the COVID-19 vaccine. The group that's on this panel today is a large group of medical professionals, and our hosts are Larry Grubler and Bert Lurch. Larry and Bert are part of our not-for-profit as well as our Healthcare Wellness Committee. This should be a very, very wide-ranging and important conversation as we read in the press that in some areas, like places in Texas, restrictions have basically been revoked. I'm not going to say it's a free-for-all yet, and things are changing in New York State. So in deference to the professionals we have, I want to thank Dr. Simpser, Dr. Ramo, and Dr. Massey for their guidance, their perseverance, and frankly, I'm going to say it, their heroism over the last year to help save lives, them and their staffs. It's so much appreciated for all you do, not only for your hospital systems, but the citizens of Queens and the citizens of New York. My hat is off to you. With that said, I'm going to turn the floor over to Larry Grubler to make some opening remarks and get the conversation started. Larry, thank you so much for being here.
Great, Tom, thanks for all you do for the Queens Chamber, the Queens community, and the city of New York. I think that it's been great working with you. And Jeff, who's the manager of the committees of the Queens Chamber and helped us put all of this together. I'm Larry Grubler. I'm the CEO of Transitional Services for New York. We're a not-for-profit mental health agency providing residential and outpatient services to anybody who has a serious and persistent mental illness. I'm also the co-chairperson of the not-for-profit committee of the Queens Chamber of Commerce, and I'm really grateful that the Queens Chamber has recognized not-for-profits as an entity, a business within the Queens community, and that's why we've chosen to be supportive of the Queens Chamber at this point. It's really great, and we've gotten a lot of benefits out of being recognized as a major player in the business world. I want to introduce Bert Lurch, and who will introduce himself as well. Go ahead, Bert.
Thank you, Larry. Bert Lurch, I'm the CEO of East Central Medical Management based out in Hyde Park, and I am the co-chair of the Health and Wellness Committee at the Queens Chamber of Commerce. Again, I want to thank all of you for joining us. This is going to be a really educational webinar, and we're looking forward to some questions, comments. So please utilize the chat, and we'll try to make sure your question is answered. So Larry, you can take it back. Thank you.
Great. So a couple of things. First, I want to thank Dan Leone, the CEO and president of QPTV, and his staff for simulcasting this event. We're really excited to partner with them to do that, and they've been extremely supportive. And we're reaching a lot more people. We have over 120 something people registered today. I think this is a great show that the topic is so important, and we've got 3 great panelists. But I definitely want to thank QPTV for doing that. I want to remind everybody that if you have any questions, this is for you. This is for the community. So if you have any questions, go ahead and put them in the chat box, and Bert and I will make sure that the panelists get the questions and they will respond to them. If there's anything that you want that's said during this meeting, rather than send it to every single person, please put your contact information in the chat box or reach out to Jeff Gross directly, and he'll make sure that you get the information that you need. I'm going to allow we have 3 great panelists, 3 medical professionals who've been actively involved in the virus and the vaccine, and they're very knowledgeable. We had an opportunity to meet them this week personally, and Bert and I and Jeff were extremely impressed. I think you're going to be very impressed with them as well. Let's start with Dr. Massey. If you could tell us a little bit about yourself, what you do, and what your experience with the vaccine and the virus has been.
Sure, thank you. Thanks everybody for listening. I'm Dr. Joseph Massey. I'm chairman of global health at Elmhurst Hospital. I'm an infectious disease internist, and I've been here for quite a number of years. We started a global health program about 2 years before COVID hit, but over the past year, it's been primarily focused on COVID, both research projects and dealing with the facts of the pandemic. Elmhurst Hospital is famous for being hit so hard in the spring, and that reflected both the community that we serve and the fact that there's a kind of a disproportionate distribution of hospitals in New York. It was a challenge for us. We had a massive expansion of our capacity. We increased our ICU beds from about 20 to about 150. They were all filled all the time in April and May. We got volunteers to help us from across the country, and we got people from all 4 branches of the military, particularly critical care people, to help us with the management of these acute patients. So it was, quite surprising, really, how, as I said, I'm in infectious diseases, and we've certainly seen outbreaks before, but nothing of this magnitude and nothing to hit so hard in the United States, sort of selectively like this. Since that time, there's been obviously a waxing and waning of cases. There's been many fewer in the fall now. So what we have now is a level loading process among the city hospitals. So we don't let anybody get overwhelmed like that, even if the numbers begin to go up, and that's working well. But it's just a reminder of what a complete shock this all was in terms of equipment needs, people needs. The impact on residents, medical residents here, was really profound. A lot of them became very depressed because of this experience, not only the death and dying, but also the focus of all of their education around this one illness at that point. We also lost several members of our staff, not doctors, but support staff who died of COVID during that period. We obviously lived it very personally. Now with a more manageable flow, we're watching our trends carefully on the new variant strains to see what impact they're going to have. And also the vaccination of even our staff has not been 100%. And what we've seen is what lots of people have seen in this area and other areas, and that's that African-American and Hispanic communities, even among medical professionals, are often somewhat reluctant to get the vaccine. And that is a challenge that we're trying to address by community outreach and various educational efforts like this one.
Great, thanks, Dr. Massey. Dr. Ramo, introduce yourself and tell us what you do and your experience with the virus and the vaccine.
Sure. Good morning, and thank you for having me. I'm Dr. John Ramo. I'm the chair of medicine at Long Island Jewish Forest Hills, part of Northwell System. As an internist who works full-time in the hospital, essentially every patient I saw in March, April, and May were patients who were admitted with COVID-19. And we're used to seeing suffering in the hospital, but not on this magnitude. And it was heartbreaking to see so many patients suffering and doing it alone. The isolation patients felt, not able to really have their friends and family at their bedside, I think made it particularly challenging for everyone involved. I think we all did our best to help make those connections through all the PPE, but the phone calls, the FaceTime, it does not replace having your loved ones at your side. So I think that particularly made it challenging for some patients. The whole time we were dealing with this, we were all looking for a way out, and some therapeutics came along that helped ease some of the suffering and helped some people get through this, but none of it was really a way out of this pandemic. I believe vaccination is our way out, but it's only going to get us there if we all fully embrace it. And we really need to do so as a community. Working full-time in Queens, this is the community that got hit the hardest. We really are the epicenter of this pandemic. So I'm really excited that we're having this discussion, and I really am optimistic that we are getting ourselves on the right path as a way out of this pandemic.
Great, thank you. And Dr. Simpser, please introduce yourself.
Good morning, everyone. I'm Dr. Eddie Simpser. I am a pediatrician and president and CEO and chief medical officer at St. Mary's Healthcare System for Children, which is based in Bayside in Queens. And St. Mary's is a unique player within the pediatric healthcare arena. We are sort of the rest of the story. We're the organization that takes care of children who've been in hospitals and who are still sick and still have medical problems, usually complex medical problems, and require care after they've been hospitalized. We have a facility in Bayside that has 124 children, as well as an array of services provided to children in their homes throughout the New York metropolitan area. And we serve about 3,000 children at any one time. And so as the pandemic hit, it was very different for us than for my colleagues who were at hospitals, not because we were not receiving COVID patients at our facility, but at the same time, dealing with children with complex medical issues, kids on ventilators, kids who are very ill, we were quite anxious, frightened that if the virus was to enter our facility, it could really be devastating to the lives of our population, much like it was in nursing homes around the whole country. And so our approach, number one, was to protect our kids as much as we could. Our staff have been extremely diligent around infection control, and our efforts around not just wearing PPEs, but hand washing and protecting our kids has been, I believe, second to none. And of course, Dr. Ramo talked about the isolation. We have the same problem where we can't have families visit very often, but we allowed families to actually live in our facility and spend full time with their children. We did not let them leave. They had to live in with us. And at one point we had 22 parents living with us in our facility, which was just amazing. We still have about 12 of them still living with us over the course of an entire year. They were living in our facility with us. And despite the fact that a large number of our staff have gotten infected, mainly in the community, we're very proud of the fact that their efforts have protected our children so that none of our inpatient children have been positive for COVID this year. And it's truly a remarkable achievement on behalf of our staff. At the same time, I shared Dr. Massey's concern about vaccine acceptance. And we have about only half of our staff, despite the understanding, healthcare workers understanding the risks, but only about half of our staff have accepted the vaccine. And we've gone through a lot of efforts to try to increase acceptance, a lot of education, and we're certainly willing to share with this audience as we go through this webinar this morning about some of that information. But it's been hard to get full acceptance of the vaccine. I'm hoping that as more and more people are exposed to vaccine and do well, that the rest of our staff and frankly the rest of the population will accept the vaccine, because I agree with Dr. Ramo. The only way we're getting our hands around this is to get everybody vaccinated.
Great, thank you for that introduction. Thank you all. So, you know, the topic of this is to vaccinate or not to vaccinate, and you are, you know, took that out of William Shakespeare. But let's go back a minute for just a few seconds to talk about the virus. And we'll fast forward to Passover, which everybody knows is why is this night different than any other night. But why is the virus different from every other virus that we've had? Why is that? What's different about it? I'll leave that to maybe Dr. Massey. What, as a infectious disease person, why is it?
It's certainly different in that it seems to affect households very readily. And there's concern about the new variants, several of them being even more contagious. It carries a death rate that is frightening, particularly for elderly people, can be close to 20% for people over the age of 70. And, you know, as you know, we've lost over 500,000 people in this country to it. And that actually is more deaths than we had in World War II, Vietnam, and Korea put together. It is a frightening epidemic, and I think it's sort of, it's unmasked some of the difficulties you have when you have 50 separate states, each with some independence and how to control it. But I think any effort to minimize this illness is really, really foolhardy. It's a bad illness. Many of us have had friends and family who've experienced it, and many of us have lost friends to it. So we have to get this under control one way or the other, otherwise we're going to be living with it indefinitely.
Okay. The questions are starting to come in. I'll just remind everybody, you have two places that you can put, there's the question and answer, and then there is the, in the chat as well. But question and answer seems to be easiest. So the question for Dr. Simpser, How many of your staff, what percentage have gone ahead and wanted to be vaccinated? What percentage are you seeing?
So in our first round of vaccines, we had about 50% of our staff vaccinated. Subsequent to that, we now have another about 15 to 20% that have come forward who want to be vaccinated. We're hoping to be able to get vaccine to do that for them, or they're going out in the community getting vaccinated. So we'll be around 65, 70% of our staff vaccinated, hopefully within the next few weeks. We really would rather get much closer to 90 to 100% of our staff. There's very few people where the vaccine is contraindicated. And so we're trying to encourage the rest of our staff to get vaccinated. I share Dr. Massey's comment about the fact that our staff from the Black communities, from the Hispanic communities, are the ones who are most reluctant. And I think that the government and the medical community have a lot of work to do, we've learned, in terms of that community and dealing with the culture of the fear that they have about the medical establishment and about the government related to medical issues.
Yeah, I definitely want to get back to that because that's a major issue. I know Bert and I have talked about that, but Dr. Ramo, how many of your staff have, I know Northwell's huge. It's like all over the place. So how many people are?
Yeah, as you mentioned, Northwell is very large. I don't have the exact numbers, but I would say that most of the health systems in this region are experiencing a lot of the same difficulties as Dr. Simpser and Dr. Massey have alluded to. We've had a huge push within Northwell to help provide education to the staff, and we have seen the vaccination rates steadily going up. I don't know the exact numbers right now, but we have had vaccination pods throughout our system, and that has really helped with the efforts we've been making.
Right. And Dr. Massey, I know Elmhurst was hit, like that was all over the news throughout the country. Elmhurst was, so what percentage of your staff have been or accepting of the vaccine?
It's very interesting. If you look at the doctor staff, particularly the Caucasian doctor staff, essentially all of them, high 90% have been vaccinated. Every other category is a step down from that, including, healthcare workers who are physicians, nurses, or from the African American or Latinx communities. And what we found is that although these individuals are often looked to as people to ask questions of within their communities, many of them endorse vaccination because that's what we're supposed to be doing, and they have not themselves gotten vaccinated. So it's really, odd. And we've heard many people refer to other, sort of dubious clinical trials that have been occurred, over the past century, particularly the Tuskegee trial, untreated syphilis. And what's amazing to me on that front is that people who were not alive within 3 decades of that trial are still very aware of it. And that's something that's hard to overcome. What we've tried to do here is what the others have mentioned. We have a lot of signs. We've had a lot of outreach into the community. We did an analysis of everybody who had COVID, rather everybody who was vaccinated early in the vaccine, effort. And again, we found that there are these distributions where Caucasian medical professionals were getting vaccinated. There was an other end of that spectrum where people would never want to be vaccinated. And there was a broad middle where people were waiting to be convinced to be vaccinated. And of course, we all have to keep in mind that herd immunity means herd of everybody. And since we're not vaccinating children yet, that means adults have to be vaccinated at even the highest rates now. And we're just not there yet. And we have not found a solution to this, although we keep trying.
Yeah, one of the questions that came up is how do you educate the African-American Black elderly population, mostly male, that this is just not another experimental drug for them to be used as a guinea pig? How do you do that?
Yeah, well, you can certainly start with the facts. There's been this concern that there was a chip embedded in the vaccine, and that's all nonsense. We encourage people not to look at Facebook to get their information. They can look at that for entertainment, but there's plenty of information on the CDC and WHO websites that's very reliable. And what we hoped, as Dr. Simpser said, is that as more and more healthcare workers get vaccinated, that more and more people will see, well, the vaccine is not dangerous and there's no bad effect of it. We have not seen that much of that secondary effect yet.
Hey, Larry.
As I've mentioned to you before, I appear on a radio show every Friday, the Caribbean Power Jam Radio at 10 o'clock. And it has an audience of over 600,000 people, primarily in New York and Queens and Brooklyn. And we go over these facts over and over and over again. And we have not yet measured to see what an impact it's having. But it seems like just telling people about it is not enough. There has to be a different level of assurance. And they have to hear it also from their colleagues, their partners, their equals in their community, not simply from medical professionals. But I think we're going to gradually see improvement, but whether it will be enough to really achieve herd immunity on the timetable we want to, that we have to remain to be seen.
I also think there's a component of, because the vaccine is new, that people are fearful of it. But I think what's important to note is that the vaccines all went through the safety trials like any other vaccine would. It has been shown to be safe and effective. And at this point, even though it's still relatively new, we've given out over 70 million doses in this country alone. And I think the last number I saw was about 250 million doses worldwide. So although it is new, it has been given out to a lot of people, and the safety profile really is there.
I think one of the concerns is from the minority community, and this is something that obviously is close to me. I even spoke to one of my employees today and asked them about the vaccine, and she's like, no way, I'm not taking it. You hear this through the minority community all of the time. And yes, you brought up a point about the safety of it. There's also a question of, how quickly it was made and what is the long-term effects of it? And how do we answer? Maybe Dr. Simpser, you can give some insight on that point.
So actually, in the education that I've done with my staff, I pointed out that despite what looks like a rapid process, and it was a rapid process relative to how vaccines have been developed in the past, the science behind the mRNA vaccine is 15 to 20 years of science that came into play. It's not brand new science. It's not something that all of a sudden that COVID came and in March 2020, somebody figured out how to make an mRNA vaccine. We've understood that this was a possible way to make vaccines for a long time. And it just so happened that the cost and the relative value of making vaccines this way didn't exist until COVID hit. And then all of a sudden, there was value to the drug companies, the pharmas, to go ahead and do this and to do it quickly because we needed a vaccine quickly. And the beauty of the mRNA technology is that it can be developed very quickly. It was still studied in over 40,000 people. And now, as Dr. Ramo has said, hundreds of millions of people have received one or the other of the mRNA vaccines. And clearly, across the board in all the countries that have been using the vaccine, the outcomes have been relatively good. You do not hear a lot of serious side effects. And what I speak to my staff about all the time is that I'm much more afraid of COVID to myself or any member of my family than I am about the vaccine. And obviously, we do not know about long-term side effects, but there's no expectation that the long-term effects of this vaccine would be any different than any other vaccine that you get. And I think one of the issues that we do have in general is that there's a percentage of the population that is afraid to be vaccinated with any vaccines. It's very hard to get 100% acceptance of flu vaccine. So we just have to continue to educate. And I do it regularly in town hall meetings with my staff and just in private conversations as much as I can, locally in my community and with my staff, trying to get people to accept the vaccine.
Another question came in. Please comment on the vaccine with patients with a history of anaphylaxis. And they spelled it right, so that was pretty good. But anaphylaxis. So tell us what anaphylaxis is, because I don't think a lot of people may know. And then what is it? How does it impact with the vaccine? Dr. Ramo, why don't you go for that?
Sure. Anaphylaxis is a form of a severe allergic reaction, which can manifest in a few different ways. People tend to think of it as difficulty breathing or difficulty with the heart continuing to pump effectively, causing either the heart rate to spike or the blood pressure to drop. It can also cause rash and some gastrointestinal symptoms. Anaphylaxis, this has gotten a lot of publicity because there was a case pretty soon after the vaccines were authorized. But when you look at the number of doses that have been given out and the number of cases of anaphylaxis that were reported, it's really a very rare effect. And it's actually in line with most of the other vaccines that we all are familiar with to begin with. For people with a personal history of anaphylaxis, I would say that they should consult with their physician about what the anaphylaxis cause is and compare it to the ingredients in the vaccine to make sure that there's nothing overlapping.
The next question, I'm considering waiting for the Johnson & Johnson shot. What are your thoughts regarding Johnson & Johnson being more potent versus the variants and less effective as far as contraction, and it seems equally effective versus death and hospitalization? So it's a multi-part question. I mean, Johnson & Johnson is just coming out. We know that it's a one-shot vaccine. We know that the statistics are, and although I heard this morning on the radio, that the statistics or the efficacy of it may not be as, maybe more accurate or more effective than they gave it credit for, because it came out or was tested during the time when the virus was really spreading all over the place. So, I just don't know. I don't have that answer, but what do you think about it compared to the other two? Dr. Massey, why don't you give that one a shot?
I think it's a good vaccine. First of all, I wouldn't recommend anybody wait for it because there's a very limited supply coming out. And it's great that Merck and J&J have joined up to make more vaccine, but Merck hasn't started producing it yet. And we have to remember that even during this relative lull we're in right now, still over 1,500 people are dying every day from this. So every day you don't get immunized, you add to your risk going forward. And as far as the Moderna and Pfizer vaccines, which are available, both of those had an effectiveness rate that was higher than anybody expected, including the manufacturers, of 95, 94% of the two. So with Johnson & Johnson, we're going to know more about its effectiveness against variant strains because it was partially studied in countries that already had variant strains emerging, but it was less effective in those countries than it was in the United States. So how it compares to the other two vaccines in variant strains, we don't know yet. All three of the vaccines seem to reduce by far drastically, completely, the risk of hospitalization and death. And that's what's so very important. Whether they all influence equally the amount of transmission a patient can give if they're asymptomatic, that's being studied right now. But my bottom line is I think the Johnson & Johnson announcement, it was good. It was good to hear it. It's good there's another vaccine coming, but it's not available now. And I've already gotten questions this morning from people who asked, should they get that as an additional vaccine to what they already got? Or, can they get their daughter lined up for it early because, they don't want to put her through 2 shots. And the Johnson & Johnson vaccine, as was said by Dr. Ramo, the other 2 vaccines have a limited small range of toxicity, very small range of severe anaphylaxis. Johnson & Johnson, as the data is coming along, has more or less the same type of range. It's not like it has no side effects. So I think the advantage is convenience, and we're going to have to see over time whether it bears out as effective. Now, one last thing I'll mention about that vaccine, since all of these companies were required to present their data after 28 days in their vaccine cohorts, that's all we know. With the Johnson & Johnson vaccine, it's now beginning to seem like protection levels continue to rise, at least for another 3 weeks after that, to a level that is close to what the Moderna and Pfizer vaccines achieve in the mid-90s. So they're all good vaccines. They're all going to be very important for stopping the outbreak. But I don't think we're at the point now of saying, yes, wait for one rather than the other. Just get whatever you can.
I also, there isn't really any logic to waiting from one vaccine versus the other than the fact that the J&J vaccine is 1 shot versus 2. The technology behind the J&J vaccine is really not that different from the technology around the mRNA, the Pfizer and Moderna vaccines. They're all using genetic material. The first 2 are using what's called mRNA, which is one type of genetic material. The J&J vaccine is using DNA instead of mRNA, but it's the same theory behind the development of the vaccine. And frankly, they're all new types of vaccines that we haven't had in the past. So I don't really see the logic of waiting. The other difference between the vaccines is that Pfizer and Moderna use ostensibly a fat globule to help get the vaccine into cells, and the Johnson & Johnson is using a virus, actually, a broken down adenovirus, to help get the DNA into your cells. So the reactions that we're seeing are usually to either the carrier, either to the lipid, the fat globule, or to the adenovirus. I don't see the logic behind waiting. To me, it's the same technology, same approach, and the same safety profiles. So I wouldn't wait.
Okay. You know, when you talk about RNA, anybody that's had, I'm not a medical doctor, but anybody that's had a biology course knows about RNA and DNA, and you learned about it at the same time. So I think, and one of the questions has to do with this. People might be afraid of getting the vaccine because especially if they're planning on having children at some point, because is it going to affect their DNA if they're getting an RNA something or another? Like, how is it going to impact on that at all? And so that's one of the questions. And also, what is the consensus on the vaccination for pregnant women and those currently breastfeeding? So it's the impact on, future childbearing and presently pregnant women and breastfeeding.
I'll start, but I'll certainly defer to my colleague. So every vaccine, the way the vaccine works is it gets cells to develop genetic material to a virus. We're just bypassing part of the process by injecting the genetic material. So to me, it isn't any different, frankly. It's just a quicker way to develop a vaccine and to get a response. And frankly, the response to the Pfizer and Moderna vaccine, as Dr. Massey pointed out, is very, very high. I was blown away by how efficacious the vaccine was relative to even other vaccines that we're very familiar with, like flu vaccine and all the other vaccines that we give out. So I think this technology is here to stay, and it's not affecting your body's DNA or RNA. It's just producing a protein that allows your body's immune cells to recognize that protein and to get heightened and be ready to attack if you get exposed to the virus. So it's not doing anything to your body's genome at all. It's not something you should be concerned about. In terms of pregnancy and in terms of breastfeeding moms, despite the fact that there isn't a lot of data on pregnant women, the American College of Obstetrics and Gynecology has come out very, very strongly in favor of vaccination for pregnant women. In fact, COVID infections in pregnant women can be devastating, not just to the fetus, but also to the moms. We already have that experience. So we are encouraging all pregnant women to go ahead and get vaccinated, obviously with advice of their obstetrician. And in terms of breastfeeding moms, frankly, all the better. Again, there's no research on this right now, but we would expect that if you develop antibodies, those antibodies may very well pass in your breast milk. We don't know that for a fact right now, but it can only be protective to your child, not going to hurt your child at all. And so I would encourage pregnant moms and nursing moms to go ahead and get vaccinated.
To piggyback on what Dr. Simpser just said, I agree there's absolutely no reason to believe there's any risk of the mRNA or DNA-based vaccines from altering our genomes. And quite frankly, the end result ends up being the same. The Johnson & Johnson, you're getting viral DNA, but ultimately that gets turned into viral mRNA, which turns into protein. So the end result, the last step of that process, is really the same for all three vaccines. You're just hitting it at a different part in the pathway.
Yeah, and if I could just add, also, I was on service in April. We saw quite a number of women who came in to deliver who were positive, and some of them got incredibly sick. We didn't have anybody die, but we had women who stayed in the hospital for weeks and weeks on a ventilator. The separation of the mother from the child was something that was hard to figure out exactly how to address that. So, we always have to compare these questions like, what's the safety of the vaccine with what's the safety of getting COVID? And in pregnant women, it's particularly likely to be a severe infection we saw.
That's a great point. I think we all look at mortality rates for a good reason. But as Dr. Massey just pointed out, in addition to mortality, there's also how sick you get and what the long-term sequelae are of COVID itself. So people may end up with blood clots that they don't die from, but that's going to affect their ability to exercise, their ability to function on a daily basis ongoing. Same thing with effects on the heart long-term. So even if patients don't necessarily succumb to COVID-19, that doesn't mean there's not long-lasting effects of the infection.
Interesting. I mean, I really love the responses to that question because it was so clearer than anything I've heard in the news and so I appreciate you delivering that because I wish we could just keep repeating that over and over again. It's really important and it was very, very clear. Another question is people with existing conditions, especially in the immune system, can they get the vaccine? Dr. Massey, as an infectious disease person. So
yeah, well, you know, of course, not all patients with all different immune system problems have been studied, but these are patients who are particularly susceptible to severe disease if they get COVID. So we're particularly concerned about the cancer patients, the HIV patients, and I think any downside to getting the vaccine there, the only downside would be it may not be quite as effective because of their immune response, but there's no downside to giving the vaccine. It's the protection that we have to offer to this vulnerable set of populations. So I think we should be actively looking for people who qualify. And, you know, most recently, they've started to stress obesity as a major concern. People who have, I think, a BMI over 30 or 33 aren't, regardless of age, are now, as long as they're over 16, are now recommended to get the vaccine because a disproportionate number of patients who got severely ill with this have been obese. So looking out for contraindications is kind of a pointless exercise, I think, because the people you're most worried about need the vaccine most of all.
Let's go back to the virus for a second because the questions are coming in and actually they're coming in fast and furious. So keep at it, guys. You're doing great. So if you've had COVID, can you get it again?
So yes, you can. You know, if you've had COVID, we don't know how long the body's our own antibodies will last for. So there have been reports of people getting reinfected with COVID. You know, in the initial time following COVID infection, that risk is lower than it otherwise would be because your body's naturally circulating antibodies. But we don't, you know, as I said before, we don't know how long it's going to last, and you certainly are at risk of getting infected down the road.
Have you seen a number of people that were reinfected? Are there people? Are there a lot? I don't know. I'm asking. I truly don't know.
I haven't seen a ton personally. I've seen a handful.
A handful.
Okay. It can be hard to tell reinfection from persistence because we don't do steady repeat studies on everybody every 4 weeks. But we've seen patients who clearly had illness, who recovered from it, who came back again with illness. And I think as they look dip more deeply for these cases, they found more and more of them. There was a study, I think, in military recruits where they find a surprisingly high rate of people getting second infections with COVID. So it is a concern. It may be a bigger concern as the variants start spreading, but it is for real.
You know, we have experience in that we are testing our staff either once a week or now twice a week for COVID. And so we have seen, again, as Dr. Ramo says, a handful of people who were testing positive, presumably positive in, let's say, May or June last year when we started testing, who have recently come back positive again after having been negative for months and months. So we're assuming that they've been reinfected. All of them have done well, and it's only been a handful. But so I think it is possible to get reinfected. Antibody immunity wanes as time goes on for lots of viruses, not just COVID. And so all the more reason for people who've had COVID to get vaccinated.
That's a good point, and that comes up to another question. How long? So if you, how long should you wait to be vaccinated if you've had COVID?
I think what the CDC is now saying is as long as you're finished with your symptoms, you should wait about 2 to 4 weeks. There is this period after infection that maybe the host immunity is protective, estimated roughly to be 90 days, but that's a rough estimate. I think getting the vaccine now, soon after you recover from your symptoms, is the best idea. We don't want to have a lot of people on various vaccine schedules because they had various types of symptoms. It's just best to move right ahead with it. And as I've mentioned before, we don't look for antibodies in patients who get the vaccine. It's not required for us to do that. So we assume that everybody is eligible.
I think Dr. Massey can correct me if I'm wrong. The only people who might want to wait a little longer are people who might have received a monoclonal antibody treatment.
Yeah, that's an important point. And, you know, that's kind of a challenge for us right now because the monoclonal antibody by Lilly, which had just one antibody, that antibody is not effective against the South African strain. So we're trying to decide whether those people should also be vaccinated at some interval during that period of 90 days where they're not supposed to be. The Regeneron products, which have two monoclonal antibodies in them, seem to overcome that problem. So at our place, we've switched over from using, you know, the Lilly antibody to the Regeneron antibody in everybody because we don't know who has the African strain and who doesn't.
For a layperson, what is a variant? How does that happen? Like you've got a virus and then all of a sudden it decides I'm going to be something else? What's, you know, just a really simple explanation of that. What is the variant?
I think a variant, a way to think of it is a mutation. And what I think it's important to realize is this is not unique to COVID. This is part of viruses' natural life cycle. Viruses tend to mutate or vary their genetic material. It's a way for them to really bypass our defenses. So this is not really something new. It's getting a lot of publicity because of the pandemic we're in. And to me, the way to stop the variants is to stop the outbreak in the first place. If we're able to remove the source of infection, in other words, if we're able to get it prevented from infecting us in the first place, they lose their ability to mutate.
So it's not just COVID that has variants. There are other things in the world that have variants. Okay. I think that's really important for people to know. I think that the way it's been publicized is that this is kind of happening just because of COVID. Okay, so somebody wanted to know about a booster shot because of the variants. Is this something that is a reality? And will this be something like an annual flu shot? What do you think? What do you think that's going to look like if you had to take a guess? Dr. Massey, go ahead.
Okay. Yeah, well, I think there is concern about the variants, and both Pfizer and Moderna are working on specific efforts to block the known variants, especially the one from South Africa, which is of most concern. But it's a little bit of there's actually a vast unknown future in this area because the variants of concern, the VOC, the ones from South Africa, the one from England, and the one from Brazil, all emerged before the vaccine even came out. So they're not a reaction to the vaccine. So we may now going forward begin to see variants develop because of the vaccine, because not everybody has been vaccinated. So you may get infected with a vaccine resistant strain now. So that's what the companies are trying to figure out and how they're going to try to approach that issue. We know in New York.
Right, can you stop for just 1 second? Because something you said was really interesting and maybe I just want to make sure I got it.
Go ahead.
So if we got everybody vaccinated as quickly as possible, then do you stop the variants?
Yes. If everybody was vaccinated at time 0 across the world, there would be no variants emerging now. Most of the variants are inconsequential. They're not worse. There's something like 400,000 of them that have been identified with this virus. There are only 3 that are considered variants of concern because they cause more severe illness. They're more easily transmitted. The one that we know most about is the one that was identified first in England, the B117 strain. And what we're doing in the United States, not as quick as most of us would have wanted, is we're starting to do genotype testing of isolations of viruses to see what variants we're actually being affected by. And it may enable us to do a more focused approach to vaccinating specific communities that are beginning to see those variants. But you know, this is something we all have to stay tuned for. What is going to be the impact of these variant strains on the disease, on the need for future immunization? Most of the strains so far seem to be prevented at least to some degree, perhaps a lesser degree than the native strain, the Chinese strain, but enough to be protected by the Mrna vaccine, the Pfizer vaccine, and the Johnson & Johnson vaccine. But it's already been demonstrated that the AstraZeneca vaccine, which they were using in South Africa, that had a big outbreak of the variant strain, is completely ineffective against that one. So that's the kind of data that they're looking at and that, you know, government authorities are going to be aware of. But if you look at the CDC daily take on this, they're very frightened of the variants and what may be coming next.
It's really interesting. Okay, to go away from this for a second, just an interesting question came up of Johnson & Johnson is being sued for their baby powder causing cancer, a product they have been manufacturing for decades. How do we know that the vaccine that they're developing is safe? How could you trust them? And I did remember hearing about the cancer. I think it had to do with ovarian cancer in women. I'm not sure, but I did hear about that a while ago. So the company made baby powder. How can we trust their vaccine?
I think it's really apples and oranges. That, you know, there's product liability all over the place, and J&J has been targeted not only for their baby powder but for their opiate drugs, and you know that's something that has to be worked out. I think those are real problems with those drugs. I think it's good that J&J has stayed in business so they can continue to try to market other things like this, but you know they have thousands of products that have not been implicated in anything as far as I know. So I wouldn't selectively say, well, J&J is a bad actor, so therefore that vaccine has to be, we have to be worried about it. And for, the Ebola vaccine that was rolled out in Africa in 2014 was based on the J&J model, and it was quite effective and safe. So we have that degree of similar vaccine data, at least so far.
If somebody has Bell's palsy, can they get the vaccine? As the person has been declined due to lack of data. I think that the person had Bell's palsy and they could not get the vaccine, it sounds like. But what do you think about that? You may also want to explain to the community what Bell's palsy is. Not everybody may know. So how about Dr. Ramo? Why don't you go for that one?
Bell's palsy is a condition that affects part of your facial nerves and can cause part of the face to droop. Bell's palsy in and of itself is not a contraindication to the vaccine. In the Mrna and the Pfizer trials, there were some small numbers of Bell's palsy in the vaccine participants. I actually believe in the Johnson & Johnson, I don't think there was any Bell's palsy reported in that one. Bell's palsy is not very common, but it's also not very rare. So it is something that we do see. And when you study a large group of people, you'll end up finding some people who end up developing Bell's palsy. But the absolute numbers in the studies of cases with Bell's palsy was very small.
I'm not even sure what this term means, but I'll ask the question. Maybe one of you do too. So if you are a long hauler, the vaccine is recommended. I'm not sure what a long hauler is. Are there any contraindications for this population? Does anybody know what a long hauler is?
Your long hauler is defined by Johns Hopkins. You've recovered from the acute elements of the infection. Okay. You've cleared your antigen, and yet you go on having symptoms, typically respiratory symptoms, some neurological symptoms, and it's a complex set of conditions and symptoms that we're trying to understand better. The rate of long haulers has been really all over the map, about 10% in this country, but China recently reported over 70% in their country. Depends on what definition you use. One of the problems with having this huge influx of patients initially is planning careful outpatient follow-up of all of them for these symptoms has been difficult. What we're doing here is we're looking at patients who had chest x-ray abnormalities to see if they become long haulers with respiratory symptoms going forward. But it's a problem. We don't really fully understand it, and it's something that I don't think we fully appreciated a few months ago.
How about people with blood clots, cardiac implications? It sounds like you might need extra caution with the decision to vaccinate. Is that true or not true?
Who's that for?
Dr. Simpser, why don't you go ahead?
And I think the opposite. You don't want to get COVID. if you have a history of blood clots. So I think you ought to get vaccinated.
After being, actually, the Bell's palsy question came up because somebody got that after the flu vaccine. Is that a possibility, or is that something that is common, or Dr. Massey does?
Well, Bell's palsy, Dr. Ramo described the clinical syndrome. It's not a condition that we can often actually identify a specific pathogen with. So it's been associated with a variety of different infections and vaccines over time. It was associated with the Zika virus a few years ago. And, as Dr. Ramos said, the incidence of Bell's palsy has not been significantly different in patients who got vaccinated to COVID than it was to patients who got vaccinated to flu. Whether any of these patients actually got Bell's palsy as a direct result of the vaccination, that nobody knows at this point. We had a patient here, one of our nurses, who after the first vaccine, she had a history of Bell's palsy. After the first vaccine I think Mrna, she developed severe relapse of her Bell's palsy. So we suggested that she not get the second dose of that, but it was all empiric. We were just guessing at that point because we didn't want to take a chance. But Bell's palsy, it's, I think so far it's been kind of overrated as a vaccine downside, but we'll have to wait and see.
Dr. Ramo, after being hospitalized with COVID and being discharged, how long should a person isolate?
So that's going to be a person-to-person decision based on how long they had symptoms, how long they were in the hospital, and how they were treated. There's not really a one-size-fits-all answer to that. In general, we do recommend about quarantine for about 14 days after the onset of symptoms, but someone may have been in the hospital for 5 days and need to isolate for another 9. Other people may have just been in the hospital for a day. So it really depends on how long you were there and how long you had the symptoms beforehand.
When can I take off the damn mask? Sorry, have to ask the question. It's up there.
From my standpoint, it's not going to be until we vaccinate enough of the community that we reach herd immunity.
So yeah, and actually I have a really good, interesting, I heard a podcast that 25% of the American population are children, and that we're trying to get to 80% herd immunity, but we can't do that unless we get the children vaccinated. So, Dr. Simpson, what do you think? Like, what?
No, it's absolutely the case, and that's part of the problem. The Pfizer vaccine was studied in people 16 and above, Moderna, J&J, 18 and above. So none of these vaccines have been studied or approved for children. Pfizer, I understand, is in the midst of a trial on 11 to 15-year-olds, and hopefully will shortly be able to complete that trial and get approval. But we don't expect to have vaccine trials in children done before the end of the year, or maybe even longer than that. And so it is going to be a challenge to try to contain this without being able to vaccinate the children. At the same time, it's pretty clear that children handle this virus a little bit better than adults, certainly better than seniors do, but they clearly can get infected and they clearly can pass it along. So it remains an issue. And part of your question around masking is, if you're in a household with children and you're taking those children out, even if you've been vaccinated, you should make sure that your kids are wearing masks too, not just you are wearing masks when you go out.
Are there specific blood types that are less likely to get COVID? Dr. Massey, why don't you try that one?
So far, there's been speculation there may be some blood type patterns in this, and it's been put forward as one possible explanation why the pandemic in Africa has not been as severe in most of the countries of Africa as it has been in the rest of the world. But I'm really not aware of convincing data. For a while we were getting blood types on our patients. We didn't see any pattern in terms of severity or likelihood of being admitted. So I think the jury is out on that at this point. Whether it's going to make a difference in management, that's always a hard thing to say too. It may help us understand, as I say, the overall global epidemiology that's a little better than we do now.
What are the recommendations on testing for those who have been vaccinated, Dr. Ramo? So if you, and this one's specifically for you. If you've been vaccinated, should you be tested, and how often? And how long do you think the vaccine will last in your system?
I'm not sure if the question's asking if you should have testing for your antibody levels or testing for the virus itself.
Testing for the virus.
For the virus.
Yeah.
I would say there's no reason for routine testing for the virus. If you develop symptoms that are consistent with the virus, then you should be tested as if you hadn't been vaccinated. You know, the efficacy of these vaccines is remarkably high. It's not 100%. So in theory, could you still get the virus and get infected? Yes, you can. So if you're having symptoms that fit the clinical picture, then I would get tested afterwards. Also, it's not an immediate response. So if you got vaccinated today, you're not going to have your full resistance to the virus immediately afterwards. So we do see some people that end up either getting sick in the short time frame afterwards, or potentially even had the virus when they were getting vaccinated, didn't know because they didn't have the symptoms yet.
And the state hasn't changed their policy around travel and getting tested, and a testing requirement, whether you're vaccinated or not. So people need to recognize if they're going to travel, the state is still requiring you to come, bring a negative COVID test.
Okay. Bert, you had a question. Why don't you go ahead?
As the chamber, business owners, it's very important to educate them. And when you have your staff, I have a question regarding educating. As a business owner, what is the best way to educate your staff about vaccinations? Maybe Dr. Massey, is something you can help out with. What is the best way as a business owner to have these conversations, or where can you point your staff to be educated on this? Because it's obviously important to keep your staff members healthy.
Sure. Yeah. Well, I think that a lot of the topics we've touched on today are good topics to go over with the staff. I think staff are in a variety of different categories, different exposure risks, and the vaccine rollout is directed toward exposure risk right now. They should understand that. They should understand that the vaccines are safe and very effective. And when their time comes to get a vaccine, they should hurry up and sign up for it. And I think wearing masks, if you're around people who don't live in your household, whether it's in an office or some other kind of business, or somebody else's house, you have to wear a mask. There's no way around that right now. And even if you've been vaccinated, unless you're only around people who've also been vaccinated, and that's kind of unusual still, you still have to wear a mask. So mask wearing is not going away anytime soon, and they have to be clear on that. But the information that's most key for people to hear is that these vaccines are extremely effective and they are quite safe. And the more people who get them, the more all of us will be protected.
Thank you. One more here. And now we talked about earlier the minority population being hit really hard. And then now on the flip side of that, they're the ones that are not taking the vaccines. Someone put in the question box about outside of education, we know that education is key. And I'm throwing this out to the entire panel, but is there anything else, and again, as a leader in the minority community, I guess one of the things is to find more leaders advocating for vaccinations, right? Because the education, you can bring a pamphlet, you can have a conversation like this, but what is going to get these individuals to get vaccinated is really something that is concerning to me. I'm just wondering, does anyone have any insight on that other than just, it's good for you to have a vaccine, it's very important. Is there any thoughts on that? Any one of you?
I think from my perspective, minority populations in this country have suffered numerous injustices. And I think until we all understand where the concerns are coming from, it's hard to address them. I think the best thing we can do is listen and actually hear what people's concerns are, rather than just trying to lecture to them and talk to them. Adults learn very differently than children. And I think that we need to make the conversation more engaging and really address very specifically what the fears are, what the concerns are, what the distrust is. And I don't think any of us have a perfect solution, but that would be where I would start with.
Thank you.
Okay. What is, when you get the vaccine, there's a protocol, I guess, for when you're fully immunized from getting the virus. So if you get the Pfizer or the Moderna, how long do you have to wait till you can feel really comfortable that you're immunized?
Well, what the data seems to suggest is about 2 weeks after the second dose, you will have reached protective antibody. Now, what they're looking at in other countries is whether one dose of those vaccines is enough to give you sufficient protective antibody. And one dose can get you into the 85% protection range. The second dose may not be as important as we thought it was, but these vaccines were studied as a 2-dose regimen, and that's where we know most about them. So 2, maybe 4 weeks after the second shot is when you can assume that you're as protected as you're going to be by that vaccine.
So, go ahead. That was me. That was a reverb. So what's the difference between, like, if I get COVID and I have antibodies, then why is that different than getting the vaccine to get protection? Why am I not just protected? Dr. Ramos.
You know, when you get infected and get antibodies, that's called innate immunity. And that does offer a degree of protection, but we don't know how long those antibodies are going to last. And there's probably numerous factors, including genetic factors and factors related to your own personal health, that are going to impact that. So we do know that the antibodies you get do wane off over time, and we have seen people get reinfected. So those are the reasons, from my standpoint, that you should still get vaccinated.
This is another question. It's kind of it's actually very interesting. HIV has been around for a really long time, and since, I guess, the 70s, 80s, probably the 80s. And it's another virus. Why wasn't a vaccine developed as quickly for HIV as it was for COVID? And do you think that there'll ever be a vaccine for that?
Well, HIV incorporates into host DNA and doesn't produce symptoms for 10, 15 years in most people. It's hidden from the immune system. COVID produces a short-term illness, and it's not hidden from the immune system. It's a big difference. I think we were all expecting an HIV vaccine. If you asked me this 10 years ago, I was hopeful. Now it does not look like there's one near, because it's such a unique virus. It's a retrovirus that copies its RNA into DNA and then inserts into host DNA. And it's very hard to get at a virus that's already inserted into the DNA. This virus, COVID, does not do that.
Okay, so that's interesting. I did not know that. So do you ever think there'll be a vaccine for HIV in our lifetime?
Well, I don't know. As I said, it seemed more hopeful than it is now. There was a lot of excitement, and Dr. Fauci, I've seen him ask that question a number of times on television now, and he gives the same sort of answer. We really don't know. We don't know what the future holds. It's great that we have good and effective treatment for HIV, and very convenient and low toxicity treatment. And it's probably more important right now on being sure that that treatment is rolled out to HIV populations. In most areas of the world, it's not. And in this country, at least, we're seeing a tremendous impact on prevention of HIV infection from everything from PEP and PrEP to treatment of chronically infected patients to get their viral load down to 0, where they're no longer contagious. These drugs really do work. They have an inconvenience that they have to be taken every day, but that's just the inconvenience that has to be addressed.
Is it, the questions are all over. So is it okay to take ibuprofen if you experience a headache after the vaccination? Dr. Ramo.
Yeah, I think part of the reason that this comes up is because ibuprofen and that class of medication, one of the things it does is it reduces our inflammatory response, which in theory is a portion of why we develop antibodies to the vaccines. So a number of people have been advocating to avoid ibuprofen or any of the non-steroidal anti-inflammatory drugs post-vaccine. I don't know if there's any real data behind that. There is a theoretical concern, but everything I've read has suggested that there's not any true evidence to that effect.
There's one thing here, and actually I hadn't heard this on the news, but if the vaccine is safe, quote unquote, why are pharmaceutical companies not liable if physical harm occurs, i.e. exempt from liability, unlike other products in the US marketplace? I did not know that. I don't know if that's a fact or not. I'm not sure. So is that true, or is that Dr. Massey?
I'm not really up to date on where they feel the liability may be there. I think they were interested in waiving liability to be sure that a significant proportion of the population got vaccinated. I think the liability of other vaccines is extremely limited. It's very rare to actually see a successful action against a company for that. But I think the companies have been somewhat indemnified by the federal government's position on this. But we'll have to see where things go. If there's an unusual manifestation the patients weren't warned about, maybe there will be a justified lawsuit.
So I guess now the question comes up: if it was your mother, sister, brother, lover, whomever, which vaccine are you recommending? Dr. Simpson, which one?
The first vaccine they can get their hands on is the one they should get.
The first vaccine. Dr. Ramo, what do you think?
I agree wholeheartedly. I would recommend everyone take whatever vaccine was offered to them first. That's what I did personally. I didn't care which one it was. Whatever was going to be offered, that's what I was going to take.
Okay. Does anybody want to disclose whether they've had the vaccine?
Sure. I had both doses.
And how are you doing? And how did it go? And how did you feel afterwards? And
I had some arm pain, a little bit of fatigue that day. That was it. And I felt good after.
felt good afterwards. Yeah, there's some talk about if you do have a strong reaction or a reaction to the vaccine, that's a good thing, that if your body's building up an immunity, so you should feel kind of crappy the next day. Is that kind of true, or is that just talk? Dr. Massey?
Yeah,
I think there's probably some truth to that, I think. Go ahead, sorry.
No, go ahead.
Yeah, I think it does indicate that you're actually getting the antigen in. And it's, since these reactions seem to be somewhat worse with the second dose than the first, it does suggest that your body has now been primed to see this antigen again. So it's a good sign, but you know, as I got both doses of Mrna, and with the second dose, I had fever and headache for about a day and was a little more tired than usual, but that was it. Nothing to be concerned about beyond that. And again, we always have to keep weighing our vaccine concerns against the actual issues of COVID.
Yeah, the questions keep coming in. It's very interesting because you have addressed it about having comorbid conditions and whether you should get the vaccine. And I keep hearing that you're saying, yes, that's the reason you should be getting the vaccine if you have sleep apnea or things that are going to make you sicker if you do get the virus. So I think that you've been very, very clear about that. I think the other thing that's really clear, and somebody commented on it, that they weren't really aware that the technology for the vaccine is actually older than just this year. I think Dr. Simpser said that before. So that I think that really comforted a lot of people that it wasn't just that it was developed, you know, over the last 6 months. This has been going on, I think you said 15 or 20 years. Am I accurate with that?
Yes, that's the research behind mRNA, and the use of mRNA and mRNA vaccines is much, much older, easily 15 to 20 years. And yes, I used that statement with my staff as well as part of my education, because I do think it's important for people to recognize that this isn't some brand new technology that got developed in February and March of 2020.
Yeah, I think, Bert, going back to the cultural issues, I think one of the things that what I'm hearing today is that there's a lot of thoughts or misconceptions. And I think that if we had almost got education about the misperceptions of the vaccine, and that if we had a list and use those for the educational piece, I think that's key. I think that's why this is really so important, because I've actually learned a tremendous amount today from the doctors, and I know that I'm getting a lot of feedback from the questions and answers that people are as well that they did not know. Okay, so let me just go down really quickly.
I got one question for Dr. Ramo. It's in the hospital there. When we were at our top, at the peak, and let's say that's a 10, what does it look like with the hospital admissions now with COVID? Where are we at now?
So comparing where we are now, we're doing much better than we were in March, April, May. We had a much lower incidence, I would say, over the summer and into the fall. And the admissions started to spike back up again, I would say late November through December and into January. They're starting to trend back down again now. I would say we are maybe a quarter of where we were in the peak season in terms of number of admissions that we're seeing. But that is still a significant amount, and it is still a real risk. And I think sometimes when people hear that, it's good to be optimistic, but not to let off the gas too much. We have to realize that it is still circulating in our community.
Go ahead, Bert.
I guess the other question to that is, in that time frame, the treatment of it, the understanding how to treat this condition has gotten better, which relates to better results of these patients being discharged, correct?
Absolutely. The treatment has gotten better. Our understanding has gotten a lot better. From my perspective, at the end of the day, the best treatment pales in comparison to prevention. So the vaccines are the single best tool we have in the fight against COVID-19.
Wow, that was clear.
Very clear.
That was very clear. Love it. Love it. What do you think life is going to look like? I understand the question. A year from now. What do you think? What do you think that we're going to be if we all worked on getting the vaccine? And what is life going to look like? Do you think it's going to look like 2018, 2019? Do you think it's going to be different? Do you think? Actually, I have another question. As a doctor, are you seeing less other illnesses in your practice or in the hospitals or wherever? Because people are wearing masks. So is there less flu? Is there less colds? Are there less, less things that people are getting because they're taking more precautions? So that's a two-part question. Are you seeing less of other things? And then what do you think life is going to look like 2 years from now?
Well, I can answer the second part very emphatically.
Okay.
We actually have data in our facility comparing from year to year, and the number, and because we test for infections in our population very regularly, and the number of viral infections in our facility dropped to near zero over the summer. That was not just because we're masking, but because we limited visitation, we limited traffic within our building, etc. So we had near zero infections for a period of time. Over the course of the late fall and winter, we have a trickle of infections, nothing like we normally see in this time, of other types of viruses, common cold viruses, flu viruses, etc. So there's a dramatic decrease in our population of other viruses, and that goes with the masking, the hand washing, and the decreased traffic in our building.
I think nationally, there's basically been no flu season this year. It came as a surprise really across the country. And, we've always prepared a lot for flu season. This year, we just stopped preparing a couple of months ago because it just does not seem to be an issue. We've had only a handful of cases. And, it's surprising how effective these measures against COVID have turned out to be against influenza. And it may lead us toward using masks more commonly than even flu vaccines in employees as we go forward, because that's the big difference. It's not like more people got vaccinated to flu, more people were wearing masks.
Interesting. Okay. So obviously, I think the community is getting the point that vaccines are important and people should get vaccinated. Would you recommend somebody not getting a vaccine for any specific reason? Is there anybody that you would say no? Dr. Ramo?
I don't mind taking this. To me, the only two reasons I can think of that you shouldn't get the vaccine is if you were treated with monoclonal antibodies or convalescent plasma within 90 days, then you have to wait. Or if you had an anaphylactic reaction to the first dose, you should not get the second dose. To me, those are the indications not to get the vaccine. Anaphylaxis to other medications is not a reason not to get vaccinated. There's very few components to these vaccines. So I think anyone with a history of anaphylaxis, their physician can pull up the ingredients in the vaccine and double check it.
How about Dr. Massey? Anybody that you would say do not get the?
Yeah, well, I think people, when they've looked at the CDC data on this, they've looked at, I think, maybe 2 million people so far who got first Pfizer, and then added the group that got Moderna. And they found that only a handful of people in that analysis had severe reactions to actually preclude future vaccination. So one lesson we learned from the flu vaccine is people who have any reaction thinks they're hyperallergic to all vaccines. We can't encourage that. This is a safe vaccine, it's effective. And if you have any concern about getting the second dose, just talk to your provider about it and have an honest discussion with them. But I would certainly lean everybody, unless you needed to be hospitalized and use an EpiPen after the first dose, you should certainly be strongly considering getting the second dose because we know that's the best way to be protected.
A question came in about mental health issues. And I think that everybody is, a lot of people are talking about the depression and anxiety that many people have experienced over this. Have you seen an uptick in anxiety, depression in your facilities, in your hospitals? Dr. Ramo?
It's a little hard question for me to answer because I'm full-time in the hospital. I'm sure there is an uptick in PTSD, anxiety, and depression in the communities. We certainly are seeing it with staff who have been caring for patients with COVID throughout, family members who have lost patients to COVID. So although I'm not personally seeing it in my practice, I think that's more a reflection of the fact that I'm practicing full-time in the hospital. I'm sure there is an uptick in our community.
Dr. Massey, how about you at Elmhurst? I know that staff must have been affected as well because there were so many cases. I mean,
yeah, well, as I mentioned, the residents really manifested a lot of depressive symptoms. We changed their schedule. As a result of that, nobody has ever run for 24 hours anymore. They're on 12-hour shifts. That seems to have helped, but of course the numbers have gone down too. And I think that, we're going to learn more about the psychological impact of all of this as time goes forward. It is a post-traumatic stress disorder for many people, either directly on their, effects or family members. And I think it's an area we're going to see more and more research on and how we should actually try to deal with it. We had a conversation with someone who does home therapy, and they were suddenly drowning in patients who were concerned and depressed because they had been exposed or thought they were concerned or any issue regarding COVID.
Dr. Simpson?
So I think one of the other issues to think about, and since this is a chamber forum, if to think about businesses and lots of people who are working from home instead of coming in, and the isolationism that comes up from working at home, constantly talking to people on a Zoom meeting or on a telephone instead of face-to-face, et cetera. I think it's important for business leaders to recognize that their employees may be suffering at home, and it's very challenging to feel. It's much easier when you have an employee in the office and you can see a change in their mental health. Much harder when your employees are working at home. And so I think we all have to have a heightened awareness of this issue and try to engage with our employees who are working from home. Maybe try to set up opportunities for socialization amongst employees who are all working in different locations instead of being together in the office. I think those are important considerations around this pandemic.
Dr. Simpson, a question came in. Did you see any cases in the kids in your facility?
We have been blessed so far that none of our children have tested positive within our facility. We also take care of about 1,200 kids in their homes through our home care program. We did have a small number of children who did get infected. We actually had 2 children pass away in our home care program who did not test positive, but some family members had tested positive. It's not clear whether they passed away from COVID or for other reasons. But in general, our experience has been quite good. I'm extremely proud of the work my staff have done in protecting our kids. The only The only sort of downside is that one way that we're protecting our kids is keeping their families away from them or limited in terms of their visitation. And that's a big, big challenge for the families and for our children.
Oh, absolutely. You've got a sick child to begin with, and now you can't really see them. That's really hard.
And when you do come to see them, you have to wear a mask, maybe a gown. It's really not the same.
It's not the same, absolutely. So let's get back to the question of what do you think life is going to be like in 2022? Dr. Massey, what do you think?
Well, I think a lot of people are still going to be wearing masks, that's for sure. If we've achieved a reasonable herd immunity, they may start relaxing some of the travel restrictions. There may be more focused efforts in areas that are hotspots. So far, it's been more or less a national, haphazard, but national campaign. And we may understand more about annual booster shots that we're going to need as we understand more about the variants and their spreading. I think, you know, there's a place for optimism in all of this because an increasing number of people are being vaccinated. These vaccines are very effective. Where we're going to land in 2022 is a big question. It depends on how many people get the vaccine and whether there are issues with variants. So the jury is out, and for that reason, I'm assuming that we'll all be wearing masks in 2022, at least for high-risk situations where we're around people who have not been vaccinated.
We're not going to eliminate COVID by 2022.
No.
So
Okay.
we have to recognize it's still going to be there. Presumably, we're not going to eliminate it. And so it's going to be around. We're going to need to figure out how to, you know, stay protected. So the question originally was, is it going to be like 2018, 2019? No, I don't think so. Is it going to be like 2020? Also, no. It'll be somewhere in between.
Dr. Ramo, what do you think?
I think somewhere in between is probably the most likely scenario. I think a lot of it is in our hands as a community. I don't think any of it's ending until we get a significant percentage of our population vaccinated. So I do think there's room for optimism, but I think we all need to do our part. And I think having discussions like this is really critically important to get the word out for the communities.
I think, Bert, if you could double check me, I think I've gotten to most of the questions on the chat and the questions and answers. One of the comments from one of the participants is that this has been an excellent participation. Please thank the presenters on my behalf, and that they hope this was taped so that they could share it with even more people, because some of the things that you said were so poignant and so clear, and I truly want to thank you for that. I haven't heard that type of clear presentation, and I know that the people that are listening are feeling the exact same way. We have three more last. I forgot to ask about Texas and Mississippi. Somebody brought that up. So what are they thinking in Texas and Mississippi? Why are they opening up the city? Somebody quoted President Biden before about what he said, but why are they doing that? Well, if COVID still exists and we're not, why are they doing that? Dr. Simpser, why are they opening up Texas and Mississippi?
So unfortunately, I'm not sure that decisions like this are made on the advice of the medical community. And I'm sure that there are a variety of stakeholders and a variety of other drivers that cause politicians to make decisions that don't seem logical right now. Seems way too soon to be opening up this. So I can't explain why they're doing it. I'm sure it's being driven by financial and business decisions more than by medical decisions.
Dr. Ramo, do you have anything to say about that?
I mean, I would agree. It's hard to answer why two states are doing things that the rest aren't. I think it's premature. Obviously, we're not living there. I don't know the ins and outs of what the community rates are. I think that there's a lot of room for optimism with the vaccines, but we haven't gotten enough of them out yet. Between the two that are out there and now the Johnson & Johnson, it should really make it more feasible to get massive amounts of our population is vaccinated. So I think to do anything until we get to that level is premature.
You also have to wonder if some of the effects of the weather in Texas over the last few weeks and trying to help people get out and recover from that is also driving some of the decision making in Texas.
Is there a potential national impact of a no mask mandate? If there was a no mask mandate, what do you think would happen? Dr. Massey?
Well, I think we already saw what happened with very spotty mask mandates, particularly in the Midwest and the upper Northwest and in the South. There was rampant progression. And I think Florida has been a catastrophic example of what happens when you're not meticulous about encouraging and enforcing mask use. And I think these steps in Texas and Mississippi, in addition to them delivering the wrong message, they're also leaving workers at risk. Then now, if you work in a restaurant or a grocery store there, you can't insist on customers wearing masks. So how is that possibly going to help us contain this outbreak? I think a decision to not wear masks at all, well, as you may know, one of the Scandinavian countries, Sweden, tried that, and they've had a much worse epidemic than the other Scandinavian countries have had. So we keep learning the same lesson, I guess, but it has to stick.
Okay. So we're going to go just around real quick. So any last words? I'll go hit each of you. Dr. Ramo, any last words to the community? What do you think?
The most important thing I could say is that the vaccines are safe and effective. All three of them fit that criteria, and I would not wait for any one over the other. I think that as soon as you're able to get vaccinated, you should get whatever is being offered. That's what I did. That's what I've had all my family do. That's what I recommend to my friends.
Great. Dr. Simpson, what's your final words?
Certainly, I agree with Dr. Ramo. As I said earlier, getting infected with COVID is much, much worse. And the risk of the COVID infection and side effects is much, much worse than any risk of the vaccine. I think the minute you're able to get it, you should run and get yourself vaccinated. It's not just for yourself that you're getting vaccinated. It's for your family, your friends, and your neighbors as well. The only way we're going to contain this is if we all get vaccinated.
Okay, and Dr. Massey, bring us home.
Yeah, I certainly agree with those comments. I would also point out that there are reliable sources of information and there are completely ridiculous sources of information. As I said before, anybody can access the CDC website just as easily as they can access Facebook. I would take your actual information that you're going to take seriously and think about and potentially act on from the CDC website. Facebook is an interesting place to have weird conversations, but it's not the place to learn about something like this.
Great. On behalf of the Queen's Chamber of Commerce and the Health and Wellness Committee and the Not-for-Profit Committee, we want to thank you for your words today. They really had a major impact on almost 100 people that participated in today's event. So Bert and I really want to thank you. So does Tom Gretsch and Jeff Gross. And you did an excellent job. The messages are coming in. Thank you, thank you, thank you, thank you. And so I really do want to say thank you. You did a tremendous job and brought a lot to the Queen's community. This will be telecast on the Queen's Chamber website. So if you want to refer people to it, it'll be up, as far as I know, on Monday. And I want to thank QPTV and Dan Leone and his staff again for doing the simulcast on QPTV. So again, thank you. This has been an excellent presentation and we really appreciate it. Stay safe, everybody. And the message is get vaccinated. Thanks again.
Thanks, Larry. Thanks, everybody.
Thank you, everyone.
Pleasure.